Very good afternoon. I'm pleased to welcome all of you at the 17th academic workshop of the cycle, the long active longevity policies and Russian and pension reforms, Russian international experience. Today, we'll speak and focus on modeling long-term care systems. And now I would like to give the floor for a welcome word from the World Bank to Nitin Umapati, Senior Economist, Social Protection and Jobs, World Bank, specializing in Russia. Distinguished colleagues, on behalf of the World Bank, I'd like to congratulate the university with the start of the new academic year, and I'm glad to welcome all participants at this another seminar as part of the cycle of the active aging policy and pension reforms, Russian and international best practices. During our scientific discussions, we're seeing that there is the acceleration of the aging process in Russia. And on the one hand, it is good news, which means that the Russian nationals start living longer. And the conclusion we may make, the inference we may make, is that the living standards have been rising, but it's fraught with difficulties also for the social protection system, because the elderly need medical help and social assistance and services, and families with elderly people would need special support. So a comprehensive system encompassing different services is needed. In the forthcoming future, near future, the number of elderly will only go up, and many of them will need institutional or home care that will entail demand for long-term care. And for the relatives and family members organizing this care on their own will be more and more of a burden. Apart from that, the nowadays policies, the current policies and the structure of the long-term care system want improvement. First of all, the strategic planning of the state policies should be focused on coming up with a sustainable model for long-term care, and the funding component should be sustainable and fiscal also. And the regulatory system should be favoring the improvement of quality, and long-term care model should foster greater role and promote greater role of the NGO, non-for-profit organizations, and other non-governmental stakeholders, and a system of surveillance and monitoring should be put in place. And the quality assurance and assessment system must be also put in place. And Russian Federation can learn from best international practices also. And for designing the governmental program, what is needed to be done is to analyze the current state and status of this system and the costs of the system. And that is about different functions of the system. And today, while modeling, we should take that into consideration. Today, we will speak about the Belarus's experience, and we'll look at the modeling methodology. We'll discuss its pros and cons. I hope for a lively debate. Thank you. Thank you very much, Nitin. Distinguished colleagues, I'm so glad to welcome all of you at the start of a new academic year. So it so happens that in the time left till the new year, we shall be talking a lot about social services and care to the elderly and long-term care. And this is the first in a seminar in a string of webinars that we will hold on related topics. And it's not accidental, it's for a reason. And Nitin has said a lot that the relevance of the nursing care goes up as the population keeps aging. But apart from the aging, there are some national priorities of the Russian Federation that definitely predetermine better living standards, especially in the elderly age. And we're seeing more people with functional constraints and limitations and impairments, and it would be impossible to ensure these living standards and life quality without the professional and informal care rendered to them. And this is a challenge that the Russian Federation is faced because currently the relatives and family members take care of those dependent relatives. And the international trends are studied, and there is a priority in the National Demographic Project. So anyway, the relevance of discussing the making of that system, that is definitely impossible without the quantitative assessments and without modeling and projecting demand for these services and the funding needs. So it is impossible to go ahead without all that. And we are grateful to the World Bank. We have had a number of seminars with them already. And I would like to thank them for the opportunity to discuss international approaches to long-term system modeling. The case study of a culturally close country, which is Belarus for us. In today's webinar, we'll proceed as follows. Mitchell Winner will take the floor. He's the Senior Social Protection Specialist from the World Bank. He will have 30 minutes per presentation. Afterwards, we'll have two panelists. Evgeny Yakushev, head of the Laboratory for Pension System Development, Institute for Social Policy, HSE, and he also has been heading the National Association of the Participants of the Social Services, and Alexander Shkribel, Executive Director of Long-Term Care Association. So these are two brilliant panelists, salient panelists that know that system like the palm of their hand. They keep modeling that, and they know a lot of legal and other regulatory issues. And afterwards, I hope we'll have a short period of time for the Q&A, and we expect to close at 6 p.m. Moscow time. So about 2 hours for us to work fruitfully. Now over to Mitchell Winner, who will speak about the experience of Belarus and projecting long-term care system costs. Over to you, Mitchell.
Thank you.
Unmute.
Yeah, I'm unmuted now. You can all hear me?
Yes, yes.
Okay. All right. Good afternoon to everyone in Moscow. Good morning to anyone who's here in Washington, D.C. I'm Mitch Weiner, as a Senior Social Protection Specialist with the bank, and I'm also the bank's Senior Human Development Actuary. So I focus a lot of my time on modeling issues for pensions and health. And the bank has very recently been trying to build similar models to look at projecting the cost of long-term care into the future. So big thanks to the Higher School of Economics for suggesting this topic and for inviting me to speak today. This, I believe, is the second time that I've participated in one of these workshops, and it's really my pleasure to be here again. Last time was about 2 years ago, and I was fortunate enough to be in Moscow for that one just a few months before COVID. As has already been said, this is a very, very timely topic globally. We are living in a rapidly aging world, especially in the Eastern European region and many of the countries of the former Soviet Union. And the fastest growing segment of the population in much of the world is the population over age 80 or over age 75. And this is also the segment of the population that has the greatest need for long-term care services. And as was mentioned, the primary support system today is family. In fact, in Belarus, by law, under their family law, the family is required to provide long-term care to aging relatives. And it's only those who don't have family support who are entitled to benefits from the state. And one of the things that we're finding is that with an aging population, the family support system is under a great deal of strain. And we're also finding that the family support is causing significant physical and mental health problems for the providers of care, for the family providers of care. And oftentimes it's forcing family members to leave the labor market So it's having significant negative impacts on the labor market as well. And as a result in this aging world, there's a greater need for government intervention in long-term care. Now, that said, I want to tell you that the results I'm showing you from Belarus today are quite preliminary. We prepared this analysis in early 2020, and I was in Minsk in January of 2020. But this was just a part of a preliminary report of a stock taking of the long-term care system in Belarus. I was one member of a team and was responsible for only the modeling aspects of our work. And our work, of course, was interrupted by COVID, and our inability to have actual missions to Minsk has really slowed our progress over the last 18 months. And while many of us we've long done projections of pension costs, and over long periods of time, over 20, 50, 75 years, projections of long-term care costs is, I would say, in its infancy. There's been a lot of work done on delivery of care, but the methodology for projecting long-term care costs, I would say, is still very much under discussion and development. This project in Belarus was the first time that I'm aware of that the bank has developed a model to try to project the impact of aging on long-term care costs over a 10, 20-year time frame, rather than just measuring 1 or 2 year costs. So this is very much a learning exercise. I'm very much looking forward to hearing the comments of the discussants, finding out what other techniques may be being used to model long-term care costs, and really looking forward to our discussion today. So if we go to slide 2, I'm just going to briefly discuss why we need actuarial analysis and some of the techniques for actuarial analysis for doing long-term care cost projections. Then I'm going to show you the preliminary results of our projections from Belarus. And if I was to summarize the findings of our study, it would be that long-term care costs accelerate even more rapidly than pension costs or healthcare costs in response to population aging. I think that would be the first big conclusion from the work that we've done. And I think the second big conclusion would be that, as usual with a lot of modeling work that we do, the real challenge is getting the data that we need and setting the assumptions that we need to do the modeling. And in particular, the kinds of data that we need for long-term care are often quite difficult to obtain and less reliable than would be the data that we would have for pensions or even healthcare. So on to slide 3. So what were we trying to do for Belarus? First of all, we were trying to prepare baseline projections of the cost of their long-term care system today. And then we wanted to see, even if they didn't change their system at all, even if the eligibility conditions and benefit levels were kept exactly the same, how would the cost of that system change over the next 20 years, solely due to population aging and solely due to increase of the cost of providing long-term care services. And here we need to say that when we talk about long-term care, we're primarily talking about labor costs, because we're not talking about medical care, and we have to clearly distinguish between medical care and long-term care provisions. And then what we want to be able to do once we have a baseline projection, and this should be very similar to what you've seen in the pension system, is we want to prepare projections of the costs or savings due to potential reforms of the long-term care system. So in terms of our work in Belarus, we're still very much on the first step, and we haven't even yet finalized the baseline projections for the long-term care system. Slide 4, please. So what are the factors that affect the cost of long-term care? Well, first and foremost, of course, is the age-sex composition of the population. As clearly as the population ages, the costs of long-term care will increase. Second, we need to know what I'm calling rates of dependency, which is how many people have a need for long-term care services by age and sex. And I will show you that this accelerates dramatically with age. Thirdly, we need to know today how many people in Belarus or in Russia are eligible for formal care, whether it's home care or whether it's institutional care, and whether the institutional care is provided through social homes or whether it's provided through hospitals. So, again, one of the challenges that we faced in Belarus is that hospitals provide both medical services and long-term care services, and we needed to be able to separate the medical expenses from the long-term care costs, and that can be quite challenging to do. And also in many countries, we have cash benefits that may be paid to caretakers. So the caretakers themselves don't need long-term care, but they're receiving benefits. And these cash benefits are also part of the cost of the long-term care system. And then for people who are receiving home care or receiving institutional care, we need to know what the unit cost of providing that care is, whether it's per year, per person, or per hospital day. And we need to know how to project those unit costs into the future. So for me, since we're building something that doesn't already exist, first of all, we want to try to find as much international experience as we can on modeling long-term care costs. And secondly, we want to start with simple models and then, over time, build to more complex models. And the complexity of the models is very much limited by the availability and quality of the data that's available. So we have to build around the data that's available, and then we need to put in place programs to start collecting better data to improve the quality of our modeling going forward. So the best basis that I was able to find for doing long-term care projections is from the European Union or the European Commission. As you probably know, they publish an aging report once every 3 years. And in the aging report, they look at 60-year projections of pension costs, healthcare costs, and long-term care costs. And so I reviewed the methodology that the European Commission was using for the aging report. And then I also spoke with the unit within the European Commission that actually prepares those projections to share information among ourselves and to find out more about their methodology. And big thanks to the European Commission because they shared a lot of the data with me. They got permission from the individual countries to share a lot of the underlying data that went into their long-term care analysis. And sometimes we can get data, but the real challenge is getting data by age and sex, because if you don't know how costs vary by age and sex, it's hard to project the impact of population aging on the cost of long-term care. Next slide, please. So here's the methodology that was followed by the European Commission in their long-term care costs for the aging report. And it's also basically the methodology that we followed for our first estimate of costs in Belarus. So we start with our population by age and sex projected out for the next 20 years. We then have dependency rates, which is the percentage of the population by age and sex that need long-term care services. And we separate the population into those that are dependent and those that are not dependent. And once we've identified the dependent population by age and sex for the next 20 years, we look at how many are receiving formal care at home, formal care in institutions, or are receiving cash benefits of some kind. And we express those as a percentage of the dependent population by age and sex. And then we look at the unit costs of care for each of those. And so we project forward the number of people in today and in the future who are likely to receive home care or institutional care or cash benefits. And what the unit costs of providing that care would be, and we multiply the number of people by the unit costs to project forward the expected long-term care costs in the future. So a fairly straightforward procedure. And for the most part, for our baseline, we just assume that whatever these rates are today, in terms of dependency rates and in terms of the percent of people receiving care today, that those percentages would remain constant across the 20-year period. And we took the unit costs and we allowed them to go up with inflation or GDP per capita or some other type of index that we felt was appropriate. Next slide. So this shows basically the same thing as on the prior slide, but just a series of steps that we followed to get to our projected costs. Now, the European Commission prepared these projections over 60 years. In my opinion, that's sort of an exercise in futility. I don't think we can. We may be able to project pension costs 60 years out, maybe as a percent of GDP, but trying to project healthcare costs or long-term care costs over a period that long, to me, is creating a false sense of accuracy. So we limited our projection to 20 years. Even that may be too long. And when we model healthcare costs, we tend to limit it to a period of 5 or 10 years because the method of delivering healthcare is changing so dramatically. And I think in many ways, the method of delivering long-term care is going to change dramatically over the next 10 years. We're seeing much more use of technology, for example, in the use of delivery of long-term care. And we may see that the models of delivery will change significantly. So even for 20-year periods, I would say we can use this just to understand the impact of aging, but to think that these projections are realistic over 20 years is probably asking a bit much. Okay, next slide. So where did we get data for Belarus for the population by age and sex? Mostly it came from Belstat. They gave us the 2017 population by age and sex, and they gave us their current and projected fertility rates. As we often do for our pension modeling, we took the mortality rates and the projected improvements in mortality rates from United Nations data. We put these into the same model that we use for our pension work, our Prost model, solely to prepare population projections for the next 20 years. And then we took the output of our pension model with the population projections and brought it into the model that we are developing for long-term care. And I suppose it would come as no surprise to you that just as in Russia, the population is both aging and shrinking, and the proportion of the elderly is increasing. So a lot of similarities to the situation in Russia. This shows the projections of the population. This is slide 8. The next slide shows the projection of the population in Belarus between 2019 and 2038. And not surprisingly, the under 15 and the 15 to 59 populations are declining. And the population over age 60 is the growing segment of the population. Now, perhaps the most challenging step is figuring out what percentage of people actually need long-term care services. So we looked at the data from what's called EU Silk. It's a database, a big database of social information on the Eurostat website for all countries in the EU 28. And then we looked more closely at the data for the newest European Union countries, Bulgaria, Romania, and Croatia. And we looked at the pattern of dependency rates that was published in the EU Aging Report in 2018. And the EU basically determines dependency rates by self-reporting. So they ask people who have severe limitations, and they ask people who have some or severe limitations with performing activities of daily living or incidental activities of daily living. So it's really self-reported survey data. But long story short, we used the rates that were used in the EU aging report, and we used the rates for the full EU 28 because they didn't differ much from the newest EU countries or Eastern versus Western Europe. But there is great variation by country in the data for the EU 28 among dependency rates, and that's a cause for some concern as it's fundamental to the projections that we're doing. But fortunately, the rates were available by age and sex. We go to the next slide. And also, just to be clear that we had these two definitions, some were severe limitations or severe limitations. Because in Belarus, the eligibility conditions for who gets benefits is quite strict, we decided to use the severe limitation definition. And it's also the definition that the European Union chose to use for their aging report. So severe limitation basically means, very roughly translated, those who need help with one or more activities of daily living or ADLs. And that includes the items shown here on slide 10. The personal hygiene, using the restroom, dressing yourself, feeding yourself, and being able to walk around, right? And then when we talk about some limitations as opposed to severe, we're talking about incidental activities of daily living, such as shopping, making meals, taking care of your house, taking care of your finances. So just to define, what the dependency rates are, what they roughly mean, and where we got the data. And slide number 12 shows these dependency rates by age from the aging report, AR, 2018. And we can see that the dependency rates, the need for long-term care, due to severe limitations, due to need with support for one or more activities of daily living, accelerates very sharply with age and really starts to grow rapidly in the 70s and even more rapidly in the 80s. And if we had a bar for 90 plus here, it would be close to 90%. And by the time people get to age 90, almost everyone needs some kind of help. Moving to slide 13. So this shows, based on those dependency ratios, you multiply the dependency ratios by the population to project the size of the dependent population or the number of people who need long-term care, which they may or may not be getting from formal long-term care programs in Belarus. So we see that we have a little less than 600,000 people that need long-term care today, and that number, just due to population aging, is expected to grow to almost 700,000 over the next 20 years. Right? And just to be clear, this includes people who are receiving both formal and informal care, and the majority of the care, of course, is informal today. On to the next slide. This is slide 14. So now we knew the size of the dependent population by age and sex. So now we looked at how many people were actually receiving different kinds of benefits from the government, right? So we had data from the Ministry of Labor and Social Protection. We had expenditure data from the Ministry of Finance, and we had utilization data and expenditure data from the Ministry of Health. And in many cases, we couldn't get the level of detail that we needed at the national level on the number of people who are actually receiving home care and institutional care. So we went to two representative oblasts of Belarus, and these statistics are kept in much more detail in Belarus at the oblast level than they are at the national level. And in some cases, the numbers were available by age and sex, and in other cases, they really weren't. And even when the data was available by age and sex, the age ranges weren't the same. So we had to make do, as always, with less than ideal data and do the best that we could with what we had and explain the limitations that imposed on us. So that's the data on how many people are currently receiving benefits. And we converted those into percentages of the dependent population. I'm on slide 15. So you can see that the percentage of dependent population receiving home care, for example, starts out at about 3%. And by the time you get up into age 80 plus, it's almost 50%. So of the people who are dependent, about 50% are receiving formal home care services from a government program. right? And there's many more. The other 50% are receiving care solely from family. And then we can see that in Belarus, institutional care is provided through social houses, which they call internats, and through hospitals. And when we talk about hospitals, there's two types of care that are received in hospitals. One, Belarus has what they call nursing hospitals, which basically provide only long-term care services and very limited medical services. And they also have nursing beds in regular hospitals. So we had to get data on both. We had to find out how many beds are used strictly for nursing care within a general hospital and how many beds there are in nursing hospitals. And one of the other quirks of Belarus, and maybe this applies in Russia as well, is that a lot of people who use long-term care use it only during the winter. And they use it because in rural areas, many of the homes in Belarus don't have adequate heating, or the cost of upgrading the heating would be too high. So instead of people remaining in their houses during the winter, even though they're capable of caring for themselves, they actually go into these nursing hospitals for the winter season because they don't have heat in their homes and it's just too cold for them to remain in their homes in the winter in Belarus. And so other than the oldest ages, you can see that informal care is still the dominant source of care. When you get over age 80, more than half of the population is receiving some type of formal care from the government. And by definition, formal care is only provided to those who don't have family to care for them or people who are very poor. On to slide 16. So this shows the percentage of people who are receiving some type of formal care through government programs, whether it's home care, institutional care, or in the hospital. And for the group that's 65 and old, well, for the population as a whole, about a little over 30% of those who need care are getting it from the government. And this is expected to increase to about 38 or 39% solely as a result of population aging, as you can see on the graph. And for the age 65 group, it's about 65% of people, 65 and older, who are getting some type of formal care from the government programs, and it increases slightly to about 68% over the 20-year period. Next slide, I'm on slide 17. And then just looking at the number of beneficiaries, it's about 235,000 people who are receiving benefits of some kind, either in kind or in cash. And that number is expected to increase very significantly to 370,000 over the next 20 years. And keep in mind, this is with no change in the current benefit program and the eligibility requirements. And notice that these numbers include significant numbers of caretakers, people who are receiving cash benefits from the government to care for those who need long-term care, primarily in a home setting. On to slide 18. Now, again, as we saw, there's difficulties in calculating dependency rates. There's difficulty in identifying, the number of beds in general hospitals and nursing hospitals that are being used. There's difficulties in getting good data by age and sex on the number of people who are using social homes or internats for long-term care. And similarly, on unit costs, we want to know how much does it cost to take care of a person for a day or a week or a month or a year or per bed day. And again, getting the total expenditures for long-term care costs and getting them separately for home settings, social settings, social home settings, and medical care settings is not particularly easy. And there is a healthcare chart of accounts. And if the chart of accounts is properly prepared, there are certain codes that should be used by institutions that are providing long-term care to clearly separate long-term care costs from medical costs. But this coding is not always fully adopted in many countries, including Belarus. And so we find that the chart of accounts for healthcare doesn't always give us accurate data about the amounts of money spent on long-term care. So we had to work quite closely with the oblasts and with the Ministry of Health to estimate what the total expenditures actually were for long-term care as opposed to other social services or as opposed to medical costs. But once we had those unit costs, moving on to slide 19, we then projected them out over time. And some of these costs were surprising to us. Excuse me. Some were not. As we would have expected, the unit costs for care at home is quite a bit lower than for unit costs for care in institutions. But what's surprising to us and what we really need to investigate further is that it appears that the unit cost for care in hospitals is lower than it is in internats or social houses run by the Ministry of Labor and Social Protection. And this is an issue we have not yet had an opportunity to further discuss with the government of Belarus. But, a priori, I wouldn't have expected that. I would have thought that the social houses would have been less expensive than care in a medical setting. So we'll need to further investigate that. Moving to slide 20. So as I said, for each type of care and for each age and sex bracket, we multiply the number of recipients by the unit costs for each year, and we add it all together to get our estimated costs of long-term care for the government. And all of this is assuming no change in benefits or eligibility conditions, and that the dependency ratios and the benefit prevalence rates all stay the same over time. So just trying to get a baseline against which we can measure any proposed reforms. So when we move to slide 21, we see what the costs of long-term care are as a percentage of GDP. And it starts out today, or in 2019, at 0.6% of GDP. And solely due to population aging and inflation, increase in the cost of services, of long-term care services, it's projected to increase to about 0.85% of GDP. So the numbers as a percent of GDP are not particularly large, but they are increasing significantly over 20 years. And as was said in the introductions by Olga, by Oksana, by Nitin, the need for the government to take a larger role in long-term care is inevitably going to increase over the next 20 years. So these numbers are likely to get much higher than what's shown here. Slide 22. So, what's our next steps for Belarus? Well, we need to have an opportunity to really present our methods, assumptions, and data sources and get further feedback from the government and see what we can do to further improve our data. Second, we need to finalize these baseline costs. And then we need to work with the government to analyze the cost impacts of potential changes in the system, whether it's to eligibility or to the benefits or to other program features. And we need to more closely examine the impact of economic development, improvements in healthy life expectancy, et cetera, on the impact of long-term care. What would happen if mortality rates continue to decrease even further and faster than what we've already illustrated. And of course, there's always a continuous job of improving the overall data quality as we say sometimes in the US, garbage in, garbage out. The quality of your output is only as good as the quality of your input. And we always need to make efforts to improve the quality of our inputs. So thank you very much for your attention. I hope you found this interesting, and I hope that it has some relevance for Russia. And I'm very much interested in hearing our discussants and learning more about long-term care in Russia and answering any questions that you may have. Thank you very much.
Thank you, Mitch. Большое спасибо, Mitch.
Thank you so much, Mitch. Thank you for being very punctual. We have exactly 5 minutes for any quick questions to the speaker. Without any comments, so let us leave the comments for Q&A. If something was not clear in the presentation, you can raise your hand, or you are invited to ask a question in the chat box. Any quick questions to specify something? At the moment, I don't see any volunteers. Lily, Zenina, over to you, please.
Thank you, Mitchell, for your presentation. It was very interesting to listen to. I have actually two small questions. Can you please clarify why you did projections in regards of different genders? So do you mean by that it's like different costs for different genders? Sorry, like do you implement like different cost projections among different genders? So like for instance, for women, it costs more or less than for men? It's my first question is if like, okay, you understand me. And the second point was, it was very interesting to hear that you explain like winter usage of old age homes by cost of heating. And I have another understanding of that. Did you take into consideration the cultural specifics of spending summer at summer cottages among like Belarusians or Russians? Also, actually true for Finland. Do you understand my question? So I really like doubt about cost for winter, like, you know, and that's why like it's the reason of usage of old age homes. But instead, I think that actually during summertime, people tend to spend their time with families in summer cottages, and winter like just is due to good reasons. Older people were placed in the old age homes, but maybe I may be wrong. What do you think about it?
Okay, to respond, thank you, Lillian. I'll respond to the two questions. Ideally, of course, we do want to get dependency rates, unit costs separately by age and sex. For the most part, I wasn't able to get separate rates for, I was able to do population projections, of course, separately for males and females, but the dependency rates were unisex. You know, we applied them the same rates to men and women. Is that correct? I would suspect not. I would think the dependency rates would differ between men and women. And you know, that's one of the data improvements that we would want to have. But even across the European Union countries, including, you know, the 15 countries in Western Europe, many of them don't have the data to do the calculations. And I guess I was actually pleasantly surprised that I got as much good quality data from Belarus as I did. I expected much worse. Because even some countries like, you know, Germany have surprisingly bad data. So you know, my expectations for Belarus were quite low, and I must say I was pleasantly surprised. In terms of, you know, of course, people do have dachas in Belarus like they do in Russia, but you know, my understanding is from them is that people actually do go into these nursing hospitals during the winter because it's cheaper to take care of them in the nursing hospital than it is to pay to install heat in their homes or to improve the quality of the heating in their homes. You know, I suspected Russia would have the same problem because you have such very cold regions in your country, just like they do in Belarus. But no, that's the actual explanation that I received from them, that a certain percentage of the people literally move into the nursing hospital or the social home for winter. Some of them may have to pay, depending on their income level, they may have to pay for those services themselves. And if they pay for it themselves, we've tried to exclude them from the study. We're trying to only study what the government pays for. And apparently the government of Belarus has concluded in many cases that for poor people, it's cheaper to just put them into the long-term care facility for 4 or 5 months than it is to try to improve their homes. So maybe I have more to learn myself. Thank you for your question.
Thank you for your response. Just I live in Finland and I work in Central Asia.
Спасибо.
Like for Finland, the summer cottages.
Я прошу.
I apologize.
true. So that's why I asked you a question about this. Like, district heating exists in Belarus, that's why. Thank you.
Спасибо, Лилия. Короткий
Thank you so
вопрос.
much, Lily. Quick question from Pavel Aptekar, and after that we'll move forward with our panelists. Well, this is just to specify. I think that this is not the cost that matters, but because in a village it is very difficult to cut wood and to fire the furnaces for the elderly. This is just too difficult for them. This is my assumption. Well, thank you so much, colleagues. We'll have an opportunity to discuss the assumptions. Mitchell, I have a quick question before I pass the floor over to our next panelist. The data on the age and sex, gender distribution, and the distribution by the severe limitations, etc., from Silk. Have you adjusted that? Bear in mind that in Belarus, the longevity is lower, the life expectancy is much less, and therefore the serious limitations may occur in a much younger age. We tried to study the limitations in Russia and the EU countries, and we see that in Russia, actually, people in much younger age will have these serious limitations. Therefore, there will be many more dependent people.
Really good point, Oksana. The short answer is no. What I did do is I looked at differences in the dependency rates between like Western Europe and Eastern Europe, and between countries like Poland and Eastern Europe and countries like Bulgaria or Romania. And I didn't find enough difference in the reported dependency rates to cause me to make any adjustments. So if I had seen that the dependency rates were very different in, let's say, Bulgaria or Romania than they were in the Netherlands or Germany, then I would have used those rates instead. But because the rates were so similar, I just used them as they are. You're probably right about your assumption that the dependency rates may be higher in Belarus at a younger age. But that would be a second level refinement to the projections that we've already done. And of course, since the dependency ratios by age and sex differ, to the extent that people have shorter life expectancies, there'll be less people subject to the higher dependency rates at age 80 and above. So indirectly, by the structure of the population, we're picking up some adjustment on the number of dependents, but we're probably underreporting the number of dependents, I think is your point, and you may be correct. I don't have enough data to be able to do it. Thank you.
Спасибо большое.
Thank you so much. So that we're proceeding with our two other speakers, and each of them will have 15 minutes each for their presentations, and I would appreciate that very much if you save us time for a Q&A. And as I said, there are two panelists, and I'm passing the floor to Evgeny Yakushev from the Pension System Survey Lab. Mr. Yakushev, you have 12 minutes for your presentation. Inaudible. Still inaudible. Thank you so much. Can you hear me now? Yes, we do hear you now. Thank you so much. Thank you so much, Mitchell, for a very interesting contribution. It's always great to get familiar with the actuarial analysis with an explanation of the methodology, and the result is very clear. We did a similar thing for Russia. We tried to assess the need for care, and we used the same methodology as was used for Belarus. So this is the OECD methodology. The costs for long-term care, I would like to focus on the specific features which were identified when doing similar calculations in Russia. First of all, this is taking into consideration regional processes. When you do a demographic focus for Russia, you have to bear in mind that Russia is not homogeneous. Secondly, there was a big issue in terms of calibration by the groups of caretakers. And Actually, the influence of the healthy lifestyle, this is something you have to take into consideration as well. Another factor, that's the change in the priorities, because Russia discusses how another system for the LTC system, another LTC system is to be brought about. And besides, we saw the shortage of the care system and major differences in costs in the regions. If we look at the demographic focus, we see the rise in women from 15 million to 20 million and in men from 7.8 million to 13 million. All in all, in Russia, we will see this number of potential caretakers. But if we look in the regions, we'll see that starting from 1990 through 2019, the share of the working age people grew by 17%, but there is a whole range of regions where, due to migration and other factors, the share of elderly grew by 70%. So in terms of the strategic planning, we have to understand these questions and bear them in mind. A key question is how we calculate non-official caretakers. And all in all, in Russia, we have 4 million people who would need that, and we try to calculate how many of them would need that informally. This is 2.6 million people who would need unofficial care. We used the census and the data from the Russian Statistics Bureau. We tried to use the same ADL scales, and 4 million, this is the lowest boundary. Other sources of data will give us even higher figures. It is quite difficult to assess and break down the caretakers by the types. We analyzed 109,000 typizations in 17 regions, and the figures differ very much. So it means that we do not have clear-cut criteria of those who need care. And in essence, taking average figures, we always run a risk that the distribution may be different from what we have in reality. This is what Oksana spoke about. Really, the Russian data show that dependency rate in Russia is high, and it starts at a younger age rather than in Europe. Therefore, in order to assess the age coefficients, we made some adjustments in order to calibrate the model. You have to bear in mind as well that calibrating the model, you have to understand that every generation, in essence, is healthier. If we look at American research, we'll see that the number of deviations, number of deficits that every generation has would grow in number from generation to generation. And the Canadian Actuarial Association says that 30%, this would be the behavioral changes that would affect 30% of the longevity. So the life expectancy in Russia did not grow dramatically. We are not different from other countries, and Russia has a huge potential to change the life expectancy and to change the health factors as well. Therefore, we have to monitor and simulate the health trends. Another question was raised by Mitchell. This is recognition of those who need the long-term care. We tried to split the caretakers into those who are provided with the long-term care in institutions and from parents or at home. So at home, there are many severe limited people who'd rather be moved to the institutions. So what do we do about the care provided by the parents. Following the legislation, the relatives really have to take care of those who need such long-term care, but the change in that criteria will result in the growth in the number of caretakers. But we tried to use the OECD approach in order to see what it may result in Russia. Actually, in Russia, 0.28% of GDP is spent on the long-term care. And if we don't change anything, this figure may grow to 0.69% of the GDP. Different scenarios are related to different criteria, different groupings of the citizens, and therefore you may see a dramatic rise in the costs on the long-term care. Besides, in Russia, we have less number of beds in the inpatient institutions, unlike other countries. That's another limitation that we have. We may see, for instance, if we look inside, we'll see that the average figure for Russia is very much different in terms of the breakdown by regions. It is different from region to region. Therefore, improving the infrastructure and inpatient care is limited because of lack of such infrastructure. If actually we proceed with the economic figures, the average figures in Russia is not the sum of the figures from the regions, because, for instance, you may see the difference in terms of the costs of long-term care at home and in the institutions, social institutions. And therefore, if we look at the average figures in Russia, we have to understand that they're very much different from region to region. And on that flow chart, you see the cost of the long-term care provided by the institution.
And quite often, there is little overlap with the regional indices of the product, food basket and the average salary. So each of the regions would approach this with different budgets. The size of the bubble or the circle reflects the budget allocated to the caretakers, to care recipients, and some of the regions have big budgets, others have small ones. Despite the fact that we'll have some indexations, we will see that the tariffs in the regions will not, the rates in the regions will not change a lot. The OPEX for social care would grow by 10 to 15% per annum. But some of the regions would reduce their spending on social services. And this is quite surprising and needs further clarification. So in our model, we have different scenarios of indexation by inflation, by average salary, and also some negative ones. And if we take the current system of social care, we have 1.5 million recipients, and by our projection, by 2040, the total number of the LTC care recipients will be increased till 2.5 million people. And there is a projection of costs for one of the scenarios that we can now consider, and we should be aware of the fact that both formal and informal care have different budgets. The overall spending of the consolidated budget is around 220 billion rubles, and 38.5 billion rubles is the co-funding by the individuals out of their pockets, and the non-refunded spending of the households is several times more. So 7.2 million people say that their daily activities include taking care for other individuals. So the state and the government faces a huge challenge of changing the criteria and recognizing the informal sectors and how to probably recognize those 7.2 million people and incentivize them somehow. And those relatives, definitely, they are distressed and they burn out, and they either reduce their working time or they step down. These may be high-skilled professionals. So what are the benefits from the modeling is moving from the qualitative assessments to quantitative ones. Like, it is so bad is not enough. We should have quantitative parameters, and we can launch the procedures of strategic planning in the social service system, as currently now we are following the same veins of the previous years, like the previous year's figure plus the inflation indexation. And given the challenge of the overall aging, the government should plan for this future need and create the necessary infrastructure. That brings me to the end of my presentation. Thank you very much. Thank you very much, Evgeny. I would ask to yield to our next panelist, our next discussant, and afterwards we'll have the Q&A. So now Alexander Scribello, Executive Director of Long-Term Care Association, Russia. So no more than 15 minutes, please. Thank you very much, Oksana. Very good day, dear colleagues. Today, I'll make a short presentation on two matters. The first one is the technology model of long-term care system applied in Russia. And the second is the econometric modeling that I'm about to present. And this is, well, just as reference, I must say that the long-term care system is being implemented since 2018. First, it was launched in 6 pilot regions. Now we are in 2021 and there are 24 pilot regions implementing and deploying the long-term care system. And we have been deploying that together with our regional colleagues for these 3 years. And we have been introducing new state-of-the-art technologies and solutions in the regions. And definitely we hope help the regions change their regulatory environment and work with the fiscal framework. And the government allocates funds to the regions. Now it's about 110,000 people are part of the LTC system. The WHO methodology was underlying ours with ICOP. And let me start my presentation. I'll try to be quick going through that. If more details are needed, I'll clarify some of the matters. So first of all, the model containing 4 main stages. Identification is number 1. We're seeing the data transfer from the health facilities to the social care facilities and social service facilities to identify those in need of LTC. Next comes type setting, typification, assessing what is the degree of the need for nursing care, or what are the types of reliance, degrees of reliance from 0 to 5, which is the scale. And if these individuals stay at home, we should define the scope of care rendered. Notch number 5 presupposes up to 28 hours of weekly care rendered to an individual. Then comes routing, the forms of the care, and the special services are defined specifically, and each family is analyzed to the extent of what help they need, and then they would launch targeted assistance to families, and they would see what monitoring is needed and surveillance is needed from the social services and medical services. And then comes long-term care for self with the home care service and the day centers and the round-the-clock institutions, and there is also a school of care. And the key elements of the model are here. And if an individual arrives at the system via a polyclinic, the doctor that referred the individual to the social service, but if that individual has a stroke or a hip fracture, the doctor would have to change the set of services, the list of services, and change the individual's record, either to increase or decrease the scope and the volume of care. So it should keep abreast. So the scope of care should keep abreast with the person's health status, current health status. So then comes the Russian situation. In all the constituent entities, in all the regions, we have, I mean the pilot regions, we have the following framework. We have the ICF as the basis, which is the classifier, assessing the vision, the hearing capacity, the need or reliance on help with ambulating or cooking and other matters. Then the results are given, and we're seeing that there is some distribution of people by the groups, and we're seeing that this is about the current recipients of the social services. Assessing 100,000 people, we may infer that the gravest are only 4%, and group number 4 is, as per that scale, is 8%, and 35% is accounted for by number 3 and number 2, number 3, groups number 2 and number 3. So long-term care encompasses only those who have a real need for reliance on others. And this system definitely is fitting in the regulatory frameworks of the regions. And each of the organizations and facilities and services acts in line with the updated standards of social services and long-term care. It is all prescribed by the regulatory acts. More than 800 new acts were adopted by the pilot regions. So let's now look at the modeling methodology. It comprises 4 stages. The first stage, we're looking whether there is, what is the projection of need for social services. Then the second is the projection of need for LTC, because only part of those receiving social services need LTC. At the third stage, we're trying to come up with a scenario of how to implement care for this number of people. And then fourth, modeling the costs. Mitchell has demonstrated a lot of slides, so I'll not repeat them, and I will cite those that are relevant for the Russian Federation. So here is the median value for the dependents, for the reliance. 8% is the Russian number, which is given by the OECD. It's quite low. And later we came with the projection of social service recipients. It's not the LTC, it's the first stage, which is the social service system. Look at the number of children by and that is similar to calculations showed by Evgeny Yakushev, and the number 1.8, the value 1.8 is the current level. And over the past years, that has been changing. That has been level, unchanged, which is a concerning thing, a concerning parameter and factor. But later we structure that, dividing as a result of the pilot projects the projected value of the individuals, members of the social services by the levels of need. I mean, the groups of 3, 4, and 5. And we look at the number of people that receive institutional and home care. We also take that into account. And the previous slide, we saw that there was a gap. 1.8 million is the current number of recipients, and we're seeing that the 4.9 is the projection for 2035. As per our projection, if we don't change our pace, you know, it's the gap will widen, the divide will widen. How shall we close this divide, this gap? We have come up with the 3 main scenarios and with the key assumptions for each of them. So I will not bore you and tire you with the details describing these scenarios. I'll just say I'll focus on number 2 that has the high pace of identification. In the LTC, there is a mechanism in place to convert the informal care to formal care. And over 3 years, we have seen what is the pace of this conversion. So we go by the upper boundary, and this is scenario number 2. Why the upper boundary? Because we have some of the mechanisms and incentives to be guided by the upper boundary. And we also take into account the changes of providing social services, because we have studied all the current modes and methods and technologies of providing and the mechanisms of providing the social services, and we could project the labor costs and the role costs, and the labor costs account for around 75% of total costs in the social services costs. And the groups of need from 3 to 5 will permanently be the focus of our analysis. We don't take groups 1 to 3. And so on the left-hand side, there are the prerequisites. I will not read them out, but on the right-hand side, we can see a figure that shows how the number of recipients will increase if we launch this very pattern. Part of the people will receive institutional care, others will stick with home care. So this schedule presents a very interesting case. Just look down. Now we're having the delta, the gap to be bridged. And now we can see how to bridge that. In 2020, around 49% of those in need of care were not included into the formal system, but with this pattern, with this model, by 2029 to 2030, that will be reduced to 0. So the informal care will be done with, and that means that up to 27% will have the increase of those who receive the institutional care. So, which is a right thing to say. It's groups 3 to 5 of the dependency. They really need the institutional care as their health status is compromised. So, and 65 plus cohort will be gaining ground, definitely. And you recall figure number 1. So, and that will be a good value versus other countries if we benchmark us against other countries. So here we can see the proportion of those receiving LTC. 2035 would have 1.9 million, and distribution the degree of need for LTC, and we're seeing that the tacit need would go to 0. So it's going to all become explicit. Here you can see that the low parameter is quite interesting. The share of social services takers in the 65 plus range of age. And we are, so the 17% is the projected value, and we are moving to be on par with other European countries. And with these data, we started the modeling process, and we have assessed the current OPEX. Only OPEX now is around 256 billion rubles, and the current coverage is 1.88 million people for the social services system. The capex is 40 billion rubles per annum, and if we model at 2.5 million people, the OPEX should grow from in the range from 438 to 670 billion rubles, and the costs will increase because the social services would not now have the same labor efficiency as is the various labor efficiency as is needed, and we'll see the growth, considerable growth. By 20% will the institutional care receivers will increase, and the home care receivers may increase by 50%. So we should improve the quality of rendering services and use the private or public partnership to minimize capex. What shall be the funding sources? Nothing new here. We're seeing that there should be an insurance mechanism put in place. So we start modeling that, and we're seeing now the current status. 90% is funded from the state budget, and 10% would be the co-funding by the recipients, and the target state would be to cover 90% of the costs by the insurance payouts, and 10% would be the co-funding. So this is the target structure, and we understand that at this point there are 24 pilot regions, and in the forthcoming future, all the 85 regions will become part of the project, and we keep calibrating. We keep assessing the regions, the pilot regions, and definitely we check and double check all the factors and coefficients in the model. I'm ready to take your questions. This is the end of my presentation. Thank you, Alexander. I think we have quite an interesting turn of our webinar. We talked about Belarus, but we also came back to the topic of modeling the care in this country, in the Russian Federation. I would like to now give floor for the discussion. Before we give floor to the the keynote speaker to respond to the panelists. So first Q&A probably should follow, and you can use the chat box. And meanwhile, I'd like to give the floor to Yuri Voronin, that has something to share on what has been voiced. No more than 7 minutes, Yuri. Thank you, Oksana. So we work online, and can you hear me loud and clear? All right. Yes. Thank you. I would straight away apologize before the colleagues that have taken the floor. I wouldn't like to downplay their work or cast doubts, but because of my character, I have to add an ointment, a fly to the ointment. I'm being quite skeptical with respect to how we are deploying our social protection system, and I will use the term the nursing care, because long-term care is an improper term. So we have the permanent nursing care prescribed in our legislation, which is the proper term, I think. But anyway, the issue
we're talking is a local one. It's about assessing the numerical values and modeling to project the costs. But speaking about the local topic, this minor topic, and letting aside the funding and the fiscal aspects, will not be able to do without any general idea in the latter respect. So, and I would not be too happy about those pilots that we have had for several years. We shouldn't be over-optimistic about them. And we started those pilots without any methodology at all. Later, at the behest of the accounts chamber and other external factors, they presented a formal methodology, very formal, like rubber-stamped methodology that had seen no public hearings or discussions. So no one knows whether that will underlie the system that will finally come up with, as I hope. So I wouldn't be over upbeat that the Ministry of Labour has some methodology, because, you know, the supervisors of that topic change quite often. There is a lot of churn in the ministry. So anyway, there are two major issues, major problems that will prevent us. I hope I'm mistaken. I hope I'm wrong. But my experience tells me that probably we will start designing the system without rough calculations on the numerical value and the resources, the financial funds. Main issue is how to assess those who need care. Alexander, with all due respect to you and your work, I do not believe that the type setting will underlie the process, because, you know, need for care is a feature of disability, and the disability is identified by the medical commissions, which is the healthcare, and the healthcare system is in charge of treatment and symptoms and the health status. But, you know, defining to what limitations this or that condition leads should be the domain of special experts. And I'm not a proponent of how we're developing this domain, the system of such experts. And I spoke at the Presidential Commission about that, and that needs improvement and better funding, but we don't have anything else. And, you know, the permanent nursing care is the degree of limitation number 3 and above. You know, and it's legally prescribed, and there are regulations, and we don't need the WHO classification, because it is a social matter of measuring and defining the constraints or limitations or impairments in your daily routines or activities. So no one would provide the expert assessment of that framework, because the legal framework of care is absent. So, and typification will not replace the legal process. So, and the final number will will be a big difference from the projection. And, you know, the manuals that the first presenter, pardon me, the benefits that the first presenter cited should not be taken into consideration, because it's the financial notion, not the social notion. And even those compensation benefits to those who are in need of care are given only to part of that contingent, those who don't work. So the potential number of those who would aspire to have the need for the care would be much greater, much greater than anything that we can have from any sources, data sources. Because what we should do, we should kind of have the bottom-up expertise, seeing those people speak up and surveying them, and sooner or later we'll arrive there at this approach, and the financial ministry definitely will have the upper hand over the labor ministry, and they will insist on that, and it is a very important matter. We cannot imagine, we cannot fancy the total number, and I'm not speaking about who's going to provide the funding, but the problem number two is costs. So here, pilots may be of help, because assessing degree 3 of limitation of self-service, you can assess that with the specific operations that will be needed. We do have the social service system. I don't like it, but we still have it in place. But the permanent nursing care segment is absent there. What we call the care in broad sense is kind of support, or probably accompanying or escorting people or something else, but you know, this is not the care per se, and the finance ministry will only provide funds to the permanent nursing care system, which is guided by the needs of the Russian regions. I'm nearing to an end.
Вы знаете, если мы говорим о сегменте постоянного ухода, тут само понятие «постоянный» определяет, что это 24/7.
Speak about the permanent care, this should be 24/7, otherwise that doesn't make sense, and meaning that we do not provide that, so meaning that we provide a little piece of that care, but the rest should be provided by you. So, and usually such long-term care should be provided 24/7 around the clock. Secondly, there should be some understanding as to what would be the pay, the compensation for the caregivers. And I agree with Eugene, what he spoke about. There is no infrastructure, and whether the country, whether the state can provide that. It means that we have to enter the market, and the market has total different pricing structure. You can calculate the prime cost because, well, for self-service is not somehow pegged to these costs. We have to proceed from the subsistence minimum wage. And there are other factors which may influence the situation. So the time period, the cost of the work, the guarantees which have to be provided, and market adjustment, because the state will not be able to cover it all. These are the factors which we have to take into consideration when determining the cost. And to conclude, would be very glad if we could approach the estimates and assessment, but unfortunately, the way the Ministry of Labor works keeps me being a pessimist. But we have to speak about that. We have to raise publicity, and the High School of Economics does a very good thing, triggering that discussion and engaging the speakers. And I do hope that our concerns would not fall on the deaf ears, especially once the new State Duma is been voted in. Thank you so much, Vladimir. Anyone wants to share comments or ask a question to any of the speakers? There were lots of very interesting facts delivered. Once again, let me remind you that you have to raise your hand, or you can write your comment on the chat box. Are there any questions? Are there any comments? While we're waiting for people to be more proactive, I have a brief comment as to what Mitchell showed. In particular, I'd like to comment on that slide regarding the unit cost of different types of care. I think the paradox that the situation that unit cost of care in nursing hospital appears to be lower than unit cost for social home. But at the moment, we are just implementing a pilot project, and almost all the services which are rendered by the social workers coming home to the people who are eligible for the social care, these would be the services which are not interpreted as the long-term care for the people with the severe limitations. I think we will have just to adjust the costs. Evgeny and Alexander spoke a lot about that. As long as the LTC systems comes into shape in Russia, the costs would grow, especially as applicable to the people with the severe limitations. I think that the Belarus case is quite illustrative. If Belarus reforms that system and provides these services to the people with most severe limitations, then the cost would rise dramatically. Besides, still I don't have any volunteers to comment on that. Let me take advantage, let me abuse my role of a moderator. I think we exchanged views on Nitin, and really the panelists spoke a lot about certain nuances as how we can do the simulation and modeling of the costs, and that's great. That's great that the pilot project on setting up the LTC system helps us to get the data that would improve the quality of modeling of costs. And Mitchell spoke about that as well, that what is no less important, and it is associated with what Victor was speaking about, for such a system, we have to look for the sources of sustainable funding. And therefore, we have certain issues in what is related to what the Russian government is developing and how we can develop, model these sources of funding. What would be the main source of funding for Russia and for Belarus? Are we going to resort to the public funding or to the social insurance? Alexander would like to comment something on what Mitchell said. Alexander, over to you. Thank you so much. Just a couple of quick comments on what I noted from what Mitchell said. Thank you so much once again for that brilliant report. Great figures and great approaches. But you gave us several statements or bullet points which, first of all, this is about the nursing care. You said that in the nursing hospitals, the unit costs are lower than in social home. Actually, this is what we saw ourselves. The reason behind that is very simple, as the staffing norms are totally different. So, meaning that in a nursing hospital, there is much less staff for providing care rather than in the social homes in Russia. So the nursing beds in Russia are being eliminated. This is a decision which is taken by the government. But once we had such nursing beds in hospitals, this was the situation which we used to have. Secondly, you said that for a winter period of time, the elderly would eagerly move to the social institutions. That is really true, especially in the north. In the northern part of Russia, this was a very frequent case. And the social protection authorities complained of that because they had to plan their activity, and there were a lot of empty beds in the summer period of time. That's not good. And how they addressed that issue? They organized extra support to the people in winter period of time. So they summoned extra personnel to provide care for these people in winter. And they engaged the Post of Russia employees for that. This is a non-standard solution, but it gave a very positive result. One question to you, if I may. You said that you got a distribution of formal and non-formal care 50 to 50% in Belarus. Probably I missed that from your report. Can you go into more details why it is 50 to 50% distribution and why? Mitch, I think that you can answer the question, and if you want to share some of your thoughts, you're most welcome. Over to you.
Okay, thank you. Alexander, I'm sorry, I didn't quite understand the question you were asking about the 50%.
Хорошо. Вы упомянули, что у вас
You said that 50% that's the formal care and 50% non-formal care, if I understood you correctly. This proportion, 50 to 50% distribution between formal and non-formal or official, non-official care. Why is it? Or it is focused? If it is a fact, then how you calculated this non-official care or informal care?
Yeah. Okay. So, I mean, the way that I got formal versus informal care was I took the whole population by age and sex. I applied the dependency ratio to get the total number of people who need long-term care. And then I identified the number who are getting it from the government. And by subtraction, the balance is informal, right? So the informal is the balancing item. And the difference between informal and formal varies a lot by age and sex in Belarus. You know, at the young ages, it's almost entirely informal. And when you get to the very old ages, it's actually over 50% are getting something from the government. I can go back and look at my statistics and give you the exact information by age and sex if you like. But on average, I think it's less than 50, but by age groups, it's much less than 50. It's some groups and slightly over by other groups. And of course, you know, the informal is rather large because only those who don't have family are entitled or who are very poor are entitled to benefits in Belarus. So the definition of the eligible group is very restricted. And it's only at the older ages where people tend not to have family and tend to be quite in need of services that you start to get over 50%. So I hope that answers your question, Alexander. As far as everything else, first of all, thank you very much for the presentations by Evgeny and by Alexander and the comments by Yuri and others. Oksana, they're really very interesting and you know, provide me with some valuable insight on long-term care in Russia and also some next steps that we might consider taking in Belarus. I think a couple of things maybe that weren't in my presentation that are worth mentioning. You know, first of all, there's a really big difference between long-term care for young people and for the elderly. And our focus in Belarus was primarily on the long-term care services for the elderly. But for young people, the costs are actually quite high. The unit costs are actually quite high because they tend to be severely disabled and often for life and need regular care. So for those who are young and need long-term care services, they tend to be quite disabled, and therefore the expenses of taking care of them are often quite high. Whereas for the elderly, it's primarily, you know, these assisting with activities of daily living or incidental activities of daily living. Second, I was really pleased to see these higher dependency ratios quantified in Russia compared with the EU or compared with the OECD. You know, I think one simple thing we might want to do in Belarus is take those higher dependency rates that you showed and apply them in our model to see what impact they have, you know, on the numbers that we've produced. Because from the EU, I couldn't get any kind of data that might indicate how much higher the dependency ratios might be in Belarus or Russia than for Eastern Europe, for example. So it's nice to see those things. Secondly, you know, I agree very much with the comment that was made that you probably have to do your modeling at the regional level and then sum the regions to get the total at the national level, because I have a lot of experience in healthcare, for example, in pricing healthcare in Indonesia, that shows that there's dramatic differences in costs by regions and that you can't just take an average, you know. And in our modeling on healthcare in Indonesia, you know, we broke it down by regions. We did the modeling by regions. We didn't do every oblast separately. We took certain oblasts and grouped them together, or their equivalent of oblasts. But still, we came up with 3 or 4 groups of regions and modeled them and then summed them to get to the total. So I think that's, you know, a really good comment. Yuri commented on the legal framework, you know, and the fact that a lot of times to get anywhere with long-term care, you really have to amend the legal framework. I mean, there's no way to expand long-term care services in Belarus without changing the family law, for example. And I'm sure there's many other pieces of legislation that would need to be adjusted. So, and this whole concept of evaluating from a medical point of view being very different from evaluating need for long-term care, and that the systems developed for medical evaluations often don't apply well to long-term care services. I agree with that. It's a different mentality and a different way of thinking when evaluating someone for need for medical services versus need for long-term care services. And yeah, the bed capacity that we talked about, that I think you mentioned it, I think, Alexander, you know, we have statistics that show exactly what you're mentioning, that the bed capacity is very different in the winter season than the summer season. And in their official statistics, they separated into the 2 seasons because of the dramatic difference in bed capacity between the 2 seasons. So, and they also plan for that because they know that the capacity is going to be higher in winter than summer. And I also agree that if you assume that you expand coverage greatly and you bring the informal sector into the formal sector, you can't just assume that your unit costs are going to stay the same and just ratio it up by counts. It's going to be leveraged up much higher than that. We find in most countries that there's a very limited amount of people available to provide long-term care services. There's a real shortage of labor. And as you grow the system, you're going to get tremendous pressures on labor and tremendous pressures on the cost of labor, which is the primary component of long-term care costs. So, you know, just to assume a straight line ratio as we bring more people into the system is not going to be the case. I agree it's going to be more of an exponential increase, and that we're probably underestimating the true costs of long-term care, you know, in the work that we're doing. The funding costs will turn out, as in most things, to be much higher than expected when the system is actually expanded. And Oksana, the issue you raise is whether of budget financing versus social insurance financing. You know, when it's very, very limited and you're only covering indigent people, people who are poor and people who don't have family, it's reasonable to think you can finance that from the budget. But if you start to expand it to broader coverage and to lesser types of disability, then it almost requires some type of social insurance mechanism or other funding mechanism to supplement the budget. There's no way the budget is going to be able to handle that cost alone when the number of people who are eligible goes up significantly. So thanks a lot for all of this discussion and inputs. I found it very interesting for our work in Belarus and for our general work on long-term care. Thank you.
Большое спасибо, Mitch.
Thank you so much, Mitchell. Thank you for your very interesting contribution, and thank you for the comments on our discussion. As far as I don't see any volunteers to speak up, I suggest that we wrap it up and suggest to slip over the information that we got. We have lots of these facts, and I would like to conclude our seminar, but before we call it a day, I would like to once again thank the World Bank, which acted as a co-organizer of that seminar. This seminar and the subsequent seminars and the whole series of our seminars are held in the framework of the Interdisciplinary Research Center, the Human Capital, Human Potential Interdisciplinary Research Center. It's been funded by the grant which was provided by the Ministry of Higher Education and Science of the Russian Federation. Let me remind you once again that we are going to meet every second or every third Thursday. And as for the moment, we are going to meet online, and I hope that eventually we'll have a hybrid mode when someone would be present offline, others would be present online, with all the advantages of online communication, when we can invite speakers from all over the world. And what we saw now, when Mitchell could join our seminar, being in Washington, and many other participants spoke from different places as well. Still, nothing can substitute for the personal communication offline. Therefore, the nearest online seminar would be held on the 4th Thursday of October. Almost all these seminars until the new year will be dedicated to different aspects related to the social service, care, or policy in the area of disabled people, people with disabilities. Remind you that can get subscribed to our newsletters, and there is a special button, and you will learn all the information at a due time. And also, you're invited to get familiar with our Facebook page. And I'd like to thank not only the speakers, the panelists, and all the participants, but I'd like to thank Olga Voron, who is our organizer, perennial organizer, and thank you, the interpreters, for the hard labor that they did, and I think they were brilliant. From time to time, I listened to the interpretation, and we, with all different velocity and speed and complexity of the speech, they interpreted that very well. Thank you so much, and see you again. Thank you.
Thanks, everyone. Good night.
Спасибо, коллеги. Всего доброго.
Всего доброго.